Greetings, I'm the dentist. Welcome back to DENTAGENDA. This is Chapter 3, Pediatric Dentistry. In this tutorial, we will discuss how to manage missing incisors in different cases. These are the points we're going through. For each patient, several factors need to be considered, and we will go through them one by one. Number 1. Skeletal relationship. In a Class 3 case, space closure in the upper arch could compromise the incisors' relationship even more, whereas in Class 2 Division 1, it would facilitate decreasing the overjet, which is desirable. Also, consider the vertical relationship, as space closure is easier in patients with increased lower face height and harder in patients with decreased lower face height. Number 2. The presence of crowding or spacing. In a patient with no crowding, space closure is difficult and requires prolonged retention. Before opening a space, it is important to ensure that sufficient will be available at the end of treatment for an adequate prosthetic replacement later on. Number 3. Color and form of adjacent teeth. Although much can be done with veneers, composite additions, or grinding, if a canine is significantly darker or coniform in shape, it will be difficult to turn it into a convincing lateral if space closure is planned by moving this canine to replace the lateral. Another situation, lateral can only be used to mimic a central incisor if the root length and circumference at the gingival margin are not significantly smaller than the other central. Number 4. Inclination of adjacent teeth. The final axial inclination of the teeth will determine the aesthetic of the finished result. Number 5. Buccal occlusion. If a good Class 1 buccal interdigitation exists, bringing the posterior teeth forward to close the space would be the preferable solution. Number 6. Unilateral loss. Note that a symmetrical result is more pleasing to the patient. Therefore, maintenance or opening of a space is preferable. If a lateral is missing and the contralateral tooth is peg-shaped, thought should be given to extracting this peg-shaped tooth to achieve symmetry. Number 7. Smile line. If the patient has a high smile line, then there is a need to consider gingival level. In some cases, they may need gingival surgery as gingivectomy. Number 8. Patient wishes and cooperation. Only after assessing the earlier listed factors, the patient can be given an informed choice. Number 9. Kesling setup. The kesling setup is a visual aid to communication between the clinician and the patient at the treatment planning stage. It helps the clinician to plan the stages and type of orthodontic treatment required and gives the patient an idea of what is achievable and what is involved. Diagnostic wax-up or kesling setup involves the repositioning of teeth once they have been cut off a set of study models, reshaping teeth by adding wax or removing stone, and also the replacement of any missing teeth. An additional benefit of including prosthetic teeth in the diagnostic wax-up is that they can be subsequently used during the orthodontic treatment to establish the corrected sized spaces. The cast should ideally be mounted on an articulator, having taken a face bow and inter-occlusion records. The advantage of this is that the dynamic occlusion can be replicated to a certain extent, so that the potential forces on the final restorations can be taken into account. If only the static relationship is considered, then this can result in the final restorations having excessive forces applied when in lateral excrusions. There is also the clinical chair-side buildup of teeth and visual setup. Number 10. Space closure. In the presence of crowding elsewhere in the arch, space closure can be facilitated by early extraction of primary teeth on the affected site. Therefore, the earlier the decision is made to close the space, the better. Active space closure requires a fixed appliance to achieve correct axial inclination. It is sometimes better to carry out any masking procedures before orthodontic treatment, like contouring the canine to resemble a lateral, by the removal of enamel incisally and interproximally, and from the palatal aspect as well, and using a composite addition, as this will facilitate final positioning and occlusion. Remember to retain with a bonded retainer. Note that the average differences in width between canine and lateral tooth is 1.2 mm, which can easily be removed mesially and distally from the canine. Number 11. Space maintenance or opening a space. If an incisor is selectively extracted and space maintenance is desired, a partial denture or acid-etched bridge should be fitted immediately after extraction. Where lateral is congenitally missing, space may need to be opened orthodontically with a fixed appliance. Some advocate encouraging the canine to erupt adjacent to the central and then retracting it to open the space to give better bone levels for implant or bridge that will be placed later on. Following space opening, retention for 3 to 6 months is advisable to allow the teeth to settle. Number 12. Resin-bonded bridges to replace the missing tooth. Number 13. Transplantation. Last but not least, number 14. Implant placement. Implant, when growth is complete, is the favorable option to replace missing teeth. And here we have a brief look over all the points. Thank you for watching. Don't forget to subscribe. I'd like to have you here for more videos. And follow us on Instagram at DENTAGENDA for extra tips and tricks.